time to discuss about the management of diabetes in pregnancy. So appreciate the importance of pre-pregnancy counseling in pre-existing diabetes and pre-diabetes individuals. Therapeutic options for the diabetes in pregnancy. So pre-conception counseling. 38-year-old obese, type 2 diabetes, to your office for follow-up visit. Blood sugars has been well controlled on metformin. She wants to have a baby and wants to know if there is any special thing to do so that her diabetes will not affect her pregnancy. So age 38 years, type 2 diabetes. Okay, and she is obese. So what would you advise her? What would you do regarding her anti-diabetic medication? She is on metformin therapy. So it's another case. Here 28 years, type 1 diabetes for the last 14 years, comes for pre-pregnancy counseling. Relevant history would you like to elicit? Examination or investigations? And how would you counsel her? So two are the different. First one is the type 2 diabetic, obese, 35 years age group. Here she is on metformin because the metformin is a drug of choice for obese diabetics. Here the type 1 diabetes, 28 years, last 14 years type 1 diabetes. So she is on intensive insulin therapy. Now the pre-pregnancy counseling. Educate and obtain the maximum cooperation from both the partners. So education about the proper control of the diabetes, education about the maternal implications and also the fetal implications, and educate about the importance of the insulin therapy and repeated examinations by the OBG and repeated referrals to the physician. So these are very, very important. And the dietary approach, dietary modifications. At the same time, you have to improve the nutrients. You have to improve the calories. But you concentrate on the more and more protein and less and less saturated fats and trans fats, more and more complex carbohydrates, less and less simple sugars, and more fiber diet. So these are very, very important in dietary approach. And some exercises. Even in the first trimester and the second trimester, both the upper limb and the lower limb exercises. In the third trimester, maybe the upper limb exercises. These are very important. Some yoga, some meditation, some respiratory exercises. These are very, very important. Obtain the optimum diabetic control before the conception. What is the optimum blood control before the conception? HbA1c less than 6.5%. Maybe 6, 5.7. That is very good. Fasting blood sugar should be less than the 100. And 2 hours blood sugar less than the 140. They are the normal values. What is the normal blood sugar values? Fasting less than 100, PP less than 140, and HbA1c 5.7. Emphasize the need for strict diabetes control to prevent the maternal and the fetal complaint. Not the control for 1 month or the 2 months or the 3 months of the pregnancy. Entire 9 months. There should be a proper control of the strict control of the diabetes. Check for the thyroid function. So the thyroid and the diabetes is a very combination. So don't be happy with that free T3, free T4, TSH, but also get the antibodies. Okay. THH, anti-TPO antibodies if required. Check the immune status against the rubella and give the vaccinations against all the possible infective diseases in the mother, like your rubella, your tetanus, okay, your hepatitis B, HB. If the patient had an history of the chicken pox, maybe the zoster injections, and maybe the pneumococcal vaccination or H influenza vaccination. So these are all pre-pregnancy counselings. Multidisciplinary approach should be encouraged. Both the OBG, endocrinology, diabetology or physician, nutritionist and the educator. So you should behave like an educator. You should behave like a nutritionist. You should behave like an endocrinologist or a diabetologist. All three by you only in a poor country like India. Okay, our people cannot afford a nutritionist consultation or a diabetes educator consultation and endocrinologist consultation, etc. And of course, we have a lot of the OBG friends with us, and we a good contacts. We have a good contacts with these OBG population. Understanding the risk. So about the congenital malformations, we discussed about the many congenital anomalies and perinatal mortality, diabetes complications of the pregnancy, obstetric complications, shoulder dystocia, etc., or fractures, inheritance of the diabetes in the offspring. What a diabetic pregnancy involves the frequent antenatal visits and close supervision. It's a team approach. A strict blood glucose control. They should have a glucometer. They should have a logbook. So what about the blood sugar in the fasting and the post breakfast or post lunch or pre-lunch or pre-dinner or post-dinner, bedtime, 3 o'clock, etc. Appropriate diet and the lifestyle modifications. And folic acid supplementation, big thanks to Ella Pragat Subbarao garu, who invented the folic acid, who invented the methotrexate, who invented the tetracycline, who invented the diethyl carbamazine or etrajan. Say, great fellow, a medical scientist par excellence. I love him a lot. So he invented the folic acid. It's a very good drug for our obese population. Folic acid being used by the neurologists, neurosurgeons, physicians. Okay, so please give them folic acid for all the pregnant women. Contraception till the optimal glycemic control. Suppose the suppose HbA1c is 9, type 1 diabetes, pre-pregnancy counseling. Wait for the pregnancy till the HbA1c is around 6%, around 100 fasting, around 140 postprandial. Don't be hurry in getting the pregnancy with the high HbA1c. Otherwise, lot of the maternal and the fetal complications will be there. Low dose of aspirin in the select cases. So that is at the OBG discrimination, the physician's discrimination. Some people they may use 75 milligrams or the baby aspirin. Maybe 50 mg aspirin is also available. That could be given these individuals, provided if they have the antibodies positive. Suppose the TPO antibodies are positive, and maybe the P ANCA, the C ANCA, maybe a background of the autoimmune diseases like the lupus or the rheumatoid arthritis, etc. There are high chances of getting the vascular events. So definitely a small amount of the aspirin will definitely works better in that individuals. See, these are all the congenital malformations. Organogenesis occur early in the first trimester before the woman reports to the antenatal clinic. So before she knows that she is pregnant, already lot of the developments in the fetus have occurred. So that is the reason pre-pregnancy counseling is very, very important in all these non-diabetic mothers. Possible abnormalities in the offspring of the diabetic mothers. In the pregnancy, congenital malformations and early IUGR. In the second trimester, macrosomia, CNS developmental delay. In the third trimester, chronic hypoxemia, stillbirths, IUD. In the newborn, respiratory distress syndrome, hypoglycemia, hypocalcemia, thrombocytopenia, polycythemia, hyperbilirubinemia, renal vein thrombosis, myocardial dysfunction, maybe cardiomyopathies. Child and adult, birth injury, behavioral deficit, intellectual deficit, obesity, and diabetes. In a single slide, I think this is one of the best slides today. See what are all the abnormalities you can see in the pregnancy, in the second trimester, third trimester, newborn, and the child, and later adulthood. So these are all possible abnormalities in the offspring. So all these should be told to the mother, both the partners. In the pre-pregnancy counseling means not to the mother alone, both the partners. You should discuss all these things with them. The achievement of the optimal glycemic control prior to the conception is the goal. If patient is on the OAD, ideal to switch out the insulin if pregnancy is the plan. So no HS in the first trimester of the pregnancy. So metformin will be the safe, but don't give the glibenclamide, don't give the sulfurias, don't give the pioglitazone, don't allow them on the gliptins or the SGLT inhibitors, etc. But always metformin or insulin in pregnancy. Whereas in Africa, they use the glibenclamide also. It is the only sulfuria which does not cross the placental barrier. But in India, we don't use the glibenclamide in pregnancy. Control of the hypertension. If suppose the patient is suppose the mother is we should not consider her as a patient, but the person is a diabetic and hypertensive. So I already told you, avoid diuretics and ACR ARBs and use other drugs. Dilated retinal exam is very, very important to rule out the retinopathy. Which retinopathy? Proliferative diabetic retinopathy. So proliferative diabetic retinopathy, no to the pregnancy. If it is non-proliferative diabetic retinopathy, yes to the pregnancy. And then the renal function. Again, the creatine clearance. Suppose the GFR is less than the 30, again, no to the pregnancy. Suppose the GFR is 70 or 80 or the 90, okay, you can go ahead for the pregnancy. Protein is also very important. Statins should be stopped. No statins during the pregnancy or the lactation. Contraindications to the pregnancy and the diabetes. This is very, very important. You all should remember. Ischemic heart disease. Coronary event in the last 6 months and ejection fraction less than 50. Don't allow them to pregnancy. Advanced untreated proliferative retinopathy for the fear of sudden vision loss during the pregnancy. Renal insufficiency. So they are present with acute kidney injury during the pregnancy and dialysis, etc. Severe gastroparesis. So they develop nausea, vomiting, etc. So definitely nutrient intakes and then all these things will be disturbed. And severe gastroparesis also don't allow them to go into the pregnancy. Uncontrolled diabetes with HbA1c more than 10 is a big contraindication. See, these are all the contraindications for the pregnancy in a diabetic individual. Need for treating the GDM, need for the treating. So for the mother, increased risk of these things already we discussed. On the infant, we have all these infections, all these implications. So effective treatment of the GDM reduces the fetal mortality to the same level as that in the non-diabetic pregnant woman. Okay, so effective treatment. So it is in your hands. If you treat the GDM very effectively, then that reduces the fetal mortality. Same level as the non-diabetic pregnant woman. That's what we need. All the book says that all the complications will be more in the pregnant woman, more and more in the pregnant woman. But if you treat effectively in the GDM, and obviously they are as equivalent as a non-diabetic pregnant woman. See, they studied, HWAS studies about 1,000 women with the GDM, randomized to receive either dietary advice, blood glucose monitoring with your glucometer, and insulin therapy as needed, or the routine care. So they have taken the two groups. One group routine care, and another group diet advice, logbook for the blood sugar estimations, and then the insulin therapy. Now they assess for the fetal and the maternal outcomes, how they fared. Infants of the women in the intervention group had lower risk of the serious perinatal complications. So obviously, in the loose group or in the routine care, more. So women in the intensive group had a higher rate of induction of the labor, but quality of the life scores were higher than the routine care group. That indicates more and more good treatment is needed. How to manage medical nutrition therapy? See, in the GDM also, not always the insulin or the metformin. I think 30 to 40% of my GDM people good, well controlled with only medical nutrition therapy. Very rarely I use the metformin. Most of 30% of my GDM popular, true GDM, the second half of the pregnancy, we can control the medical nutrition therapy. Good exercise is very, very important. Not insulin, then you add the oral diabetic agents like metformin and then the insulin. Here 26-year-old primey, GDM during the 27th week of the gestation, fasting and postprandial 87 and 182. 158 centimeters tall and weighs 91 kgs. So obese, she is vegetarian, she follows a sedentary lifestyle, but tries to go for a walk for 15 minutes every day. So what advice would you give her regarding the diet and exercise? Okay, so tries to go for a walk for 15 minutes every day or once in a week. Because she is giving you a lot of scope for your advice. So you should advise her because she is obese, 91 kgs. So your dietary approach, so how to reduce the body weight, etc. But you maintain the calories. But the same time you give the good calorie diet rather than the poor calorie diet. So dense calories, etc. avoid. And then, yes, she is a vegetarian. So you have to improve the proteins also, vegetable proteins. So mixture of your dals. Okay. So Bengal dals, etc. And also the soya beans. These are all very good for the protein diet. And then the more milk, more fruits, etc. And then the exercise is very, very important for her because the weight is 91 kgs. Cornerstone of the GDM management is the medical nutrition therapy. Some women in the GDM will be able to manage their blood glucose levels effectively with MNT alone. Fulfill minimum pregnancy nutritional recommendations for the pregnancy. Achieve the glycemic goals without weight loss or undue weight gain. See, we expect the weight gain to the kgs about 8 to 12 kgs weight gain is usually required during the pregnancy for the proper growth of the fetus. But if the weight gain is more, say 15 kgs, 20 kgs, that is bad. In the same way, weight gain of 5 kgs or 6 kgs is also bad. So you maintain that weight gain at least about 8 to 12 kgs during the pregnancy, and then wait for and then aim for the other things. Avoid ketonemia, ketonuria from the calorie restriction. So more the starvation, so more the ketones. Again, the more the ketones harmful to the fetus. So no starvation during the pregnancy. So no feasts or no fastings. So starvation, obese and overweight women can be advised moderate carbohydrate and calorie restriction. So these are, there is recommended net weight gain in the diabetic pregnancies. Diet, the calories, first trimester, so 30 to 32 calories per kg body weight. Second, third trimester, maybe 38. Carbohydrate, 50 to 55%. Fat, less than 30%. Protein, not 1 to 1, normally 1 gram per day. 1 gram per kg body weight. But in pregnancy, we give 1.5 to 2 grams per kg. Fiber, more fiber is always good. Attain the recommended weight gain in the pregnancy. Obtain the ketosis and IUGR. Avoid the ketosis and IUGR. Endure the euglycemia and successful outcome of the pregnancy. And see for the good less fatal morbidity and less fatal mortality. So this is the medical nutrition therapy recommended daily intake. Your proteins, vegetable fat, vitamin A, folic acid, calcium, iron, vitamin B12. So most of our Indian women, they are the anemic. So anemia also has to be corrected. You see that anemia, whether it is microcytic anemia or normocytic anemia or the macrocytic anemia, according to your MCV, etc., and then treat accordingly. Unfortunately, anemia means always gives iron, without seeing your MCV and MCH and MCHC, or your serum iron levels or ferritin levels, iron binding capacity. So these are the minimum investigations one should look for while dealing a case of the anemia. In the same way, vitamin B12 estimations, vitamin D3 estimations, these are also very important. Sometimes you may need a hemogram, you may need a bone marrow aspiration, etc. So meal plan should be tailor-made and easy to understand and to follow. That is very, very important. A small frequent meals are ideal to avoid the hypoglycemia, avoid prolonged fasting. Bedtime snack is advisable to prevent the development of the ketosis at the night and ensure adequate hydration, about 8 to 10 glasses of the water per day, and avoid the fruit juices which contains a lot of sucrose or the fructose. The following non-nutritive sweeteners are considered safe during the pregnancy. The following non-nutritive sweeteners are not considered safe during the pregnancy, like saccharin and the silanine. Physical activity is recommended 30 to 45 minutes per day. So she's trying about 15 minutes a day, but usually 30 to 45 minutes per day is recommended physical activity. That is a planned physical activity. Complements the dietary recommendations. So diet plus exercise. Activities that increase the blood pressure should be avoided. Lifting heavy weights, pushing heavy objects, etc. Upper body resistance training has been shown to reduce the glucose levels in the third trimester. So upper body exercises, even though the person is in the third trimester, if physical activity is restricted by the obstetrician, then the patient should adhere to this advice. Here, 34-year-old second gravida, GDM at 27 weeks gestation. She was put on the lifestyle modifications, which follows very rigorously. After 2 weeks, her results are fasting 98, 2 hours postprandial 156. Are you happy? Is the glycemic control adequate? No. Fasting should be less than 90 and 2 hours postprandial should be less than 120. So what is the next line of the management? In spite of your dietary approach and exercise, now you have to put some drugs. Okay. Here 28-year-old second gravida, OGTT with 100 grams of the glucose at 24 weeks. Here results. Fasting 138, 1 hour 259, second hour 217, third hour 198 at 28 weeks, 24 weeks gestation. Very high blood sugars, almost like a pre-existent diabetes. Okay. So what treatment would you advise? Only diet and exercise here. So diet and exercise plus medications. So diet and exercise, yes. Metformin, provided if the patient is also having the obesity, etc. But insulin, yes. Maybe not 1 yes, maybe 3 yes or 4 yes. That means you have to give basal bolus therapy here. So fasting is more, first hour is more, second hour is more, third hour is more. So your goal is 90 and 120. It's very difficult to achieve with only 1 shot or 2 shots of the insulin. So she may require 3 to 4 shots of the insulin a day, maybe basal bolus therapy. Okay. Then in that way, I don't use the metformin also. So straight away, dietary advice, some exercise, and give insulin, like your regular insulin, like Fiasp, etc. So before breakfast, before lunch, before dinner, and give one basal insulin like Lantus or the Deglutec at the bedtime. That's how we have to treat these population, because otherwise, no, 24 weeks we have to treat her till 38 weeks or the 39 weeks. So unless otherwise, these people will have a lot of the complications. There will be the maternal and the fetal consequences will be very, very high. So this patient has to be admitted also, provided if you want to control the blood sugars very effectively. For example, if I say that 5 minutes before the breakfast or 10 minutes before the lunch, and unless you see the blood sugars after 2 days or the 3 days, still after 3 days, the fasting blood sugar is 100. So you have to increase the dosages of the basal insulin. Suppose 1 hour 259. So after 3 days or the 4 days pre-lunch, maybe 200. Again, you have to increase the regular insulin what you are giving before the breakfast. So this is very, very important. These cases has to be admitted at least for 3 to 4 days for the proper management of the diabetes and to identify the what dose of the insulin is required for her to achieve the euglycemia. That is very important. Whether they pay or not, it is a secondary matter. But you have to see that both the mother and fetus must be healthy at the time of the delivery. So you have to control the blood sugars very, very effectively. So when the patient is very poorest of the poor, we have to see them even without any cost, or you have to admit the patient without charging anything also. So this is very, very important. So sometimes we have to go for the charity, and this case is the one of the important case for the good charity work, provided the patient cannot afford. Now the insulin therapy. Insulin is essential if the medical nutrition therapy fails to achieve the euglycemia by 2 weeks. Fasting glucose more than 95, 2 hours more than the 120. Consider insulin therapy at the time of the diagnosis if the glucose levels are high. So that's what I told you here. So when the glucose levels are very high, we have to consider the insulin. That's what they are saying that. See the glycemic targets. So you know all these targets, 95 and 120. So your DIPSI says 90 fasting and 2 hours 120. Here the options. You have the different options. You know that insulin is required for the insulin, but don't be worried about the insulin therapy. It's the very, very easiest way to start the insulin therapy, and it's very nicely we can control the blood sugars effectively with the present insulins. So regular human insulin, yes, like your Actrapid, etc. But one thing is very clear that these Actrapid or your hum insulin R or Osilin R, they are available at the price of 140 or 150 rupees a vial. It contains about 400 units. So you have to wait for at least half an hour between the food and the insulin intake, because the insulin present in your Actrapids and these insulins are in the hexameric form, and they have to be converted to the monomeric form for the therapeutic action. So you have to wait for the half an hour. That is a very, very important advice. Otherwise, what will happen if they taken this Actrapid injection and immediately within 5 minutes they take the breakfast or the lunch, the blood sugars will be very high. But even though they take the insulin is not at action right now. So it will act after 45 minutes or the 1 hour. So by that time the blood sugars will be very, very high, and again that causes a lot of the consequences. So this is a very important point. You have to tell to the patients that when the patient you are putting this type of the insulins, these patients has to wait for that period. Suppose the patient can afford, they can't wait that period, and definitely can use the analog insulins which act immediately, like your Fias for the Novo Rapid. They act within the 5 to 8 minutes after giving the injection. Sometimes even they forget the injection. Immediate after lunch at the dinner also they can take the insulin, and the blood sugars will come down very effectively. So see, when you are in the private practice, a lot of the people are referred people only to comers. So definitely I use that analog insulins for these benefits. NPH insulin, yes, that is a long-acting insulin, not 24 hours acting insulin, maybe 12 to 18 hours action. So you have to give the BD or maybe the bedtime insulin to reduce the fasting blood sugars. Rapid-acting insulin analogs, I already told you the Lispro and the Aspart, they are the very beautiful injections, but the cost is much higher. Here the 400 units of Actrapid costing about 160 or 170 rupees, whereas the Lispro and Aspart 300 units costs about 700 to 800 rupees. So 700 to 800 rupees, 300 units. You are using 5 units or 10 units or 20. So for about 10 days or 15 days, you can have that. So if you divide it per day, hardly 80 rupees or the 90 rupees. Now anyone can afford. Okay, it's not 300 single day. Suppose in the antibiotics now, if you want to use the Tazopact, that is costing about 450 rupees MRP. Of course, you will get it for 100 rupees or 120 rupees. That is a different story. But the patient has to buy for 350 rupees or 450 rupees for one 4.5 grams of Lutajobact. So you have to give three shots a day. So per day, they have to spend about 1500 rupees to 2000 rupees for antibiotics alone. One patient of me is on meropenem 1 gram 6th hourly. So meropenem 1 gram is costing about 800 rupees. So imagine per day 3000 to 4000 rupees only for the antibiotics. In that way, the cost of these, even your analog insulins is much cheaper. Suppose if you tell all these things, those people who can afford, so definitely they will convince and then can give this. Because if they convince for the analog insulins, so the treatment must be very easy because they may not wait. And the second thing is they are fast acting. So they last for about 3 to 4 hours. So whatever the food they take it, so you give this injection exactly matches to your physiological hyperglycemia. And again, when the food is not there in our stomach after 2.5 or 3 hours, the insulin is also not there. So the chances of hypoglycemia will not be there. Otherwise, what if you give the Actrapid now, if the patient takes the food, maybe idli or maybe dosa, etc. So this idli or dosa will last in the stomach for about 1.5 hours to 2.5 hours. But your Actrapid will last for about 4 to 5 hours or 6 hours. So even though there is no food in the stomach, this insulin will cause hypoglycemia at a later time. So immediately it causes hyperglycemia because it's not working immediately. But after before the lunch or before the dinner, they cause hypoglycemia because of the onset of this action at a later time. I hope I convinced you. So that is the reason those people who can afford always go for these analog insulins, much better in controlling the blood sugars very effectively. So premix insulins are the very big brands in India, very popular insulins in India, like your Mixtards, your Voslin 30/70, Hamilton 30/70, etc. So they have 30/70, 25/75 and 50/50. What is this 30/70? 30 is the regular insulin and 70 is the NPH insulin. 50/50 is also same. So 50 is the regular insulin, that 50, another 50 is our NPH insulin. So if you give the Mixtard morning time, maybe 25 units. So 25 units, you are giving the Mixtard, that is 30%. So how much 25 units 30% means? Maybe 7 units or 7.5 units is the regular insulin, and the remaining is the long-acting insulin. And then give the long-acting insulin analogs, your Detimir, your Glargine, or your Deglutec. Yes. So this is the time action profiles of the insulin preparations. See here, very important chart here. See the insulin Lispro, Aspart, Glulicin, immediately they act. Okay, and it lasts for about 3 to 3.5 hours. And regular insulin taking some time, and then acts for about 5 to 6 hours, etc. And the NPH insulin, and then a Detimir and the Glargine. If you see the Glargine, no peakless insulin. If you take the NPH, it has a peak. So chances of hypoglycemia at the midnight is also possible with the NPH insulin. So insulin therapy has to be individualized. No convincing evidence for the superiority of the one insulin regimen over the another. I don't agree it. So definitely there is a convincing evidence that the superiority of the basal analog insulins over the regular insulins. Postprandial glucose values need special attention in a pregnant diabetic woman. Yes. Many women with GDM have elevation of the single post-meal glucose levels. In such cases, a single dose of the regular insulin before the meal may suffice. That is very good. Most of our people know, in the true GDM people, I use only one shot or maybe the 2 shots. They don't require the basal bolus therapy because they diagnose the GDM at 28 weeks or 30 weeks of the pregnancy. And if you give the 5 units or 6 units or 10 units before the lunch, that may be the sufficient for most of our GDM population. But we are much worrying about the pre-gestational diabetes. If they get the diabetes in the first half of the pregnancy, so you need multiple insulins and also a basal bolus therapy. Now 4 units on the rapid acting insulin before the breakfast. You started on the insulin therapy. You started with the 4 units before the breakfast and advised to monitor blood sugar levels daily. She does well. After 2 weeks, so this is the reports. She is compliant with the diet, exercise and insulin. So fasting 118, Postprandial 126. Is your glycemic control is adequate? No. So your goal is fasting 90. 2 hour postprandial 120. So what is the next line of the management? So that is the right answer. Maybe NPH insulin or your basal insulin to reduce the fasting blood sugar, because you are giving the regular insulin before the breakfast that controls only postprandial hyperglycemia, not the fasting hyperglycemia. The dose of insulin is the trimester specific. Insulin doses need the individualization based on the carbohydrate content of the diet. Start with the low dose, maybe 4 to 10 units per day, depending on the blood glucose levels. Titrate frequently till the target levels are achieved. Dosage of the insulin normally increases as the pregnancy advances. If the fasting levels are high, the woman may need to put on the basal insulin at the bedtime. After lunch or after dinner, glucose levels are the high. Short-acting insulin need to be added before these meals as well. Basal bolus in some cases. Insulin analogs, already I told you the advantage of these insulin analogs. Long-acting analogs, that is also most advantageous. Premix insulins, not the ideal type of insulin pregnancy since it comprises the flexibility. So this is a very, very important. Okay. So why this is important, I will give you a story. Suppose however, it is more convenient to the patient and may improve the compliance. So it is convenient to the patient and may improve the compliance because morning one shot mixed start and the night one shot. Morning her daughter or daughter-in-law will give the injection. Sorry, daughter because pregnancy kada. Maybe mother-in-law, mother-in-law or the husband or the father-in-law will give the injection, and the night time again these people will give it. But the problem with the mixed insulin is, suppose you are advising her the 20 units of the mixed in the morning time. So how much is the regular? How much is the NPH insulin? 30% means 6 units. So 6 units is the regular insulin and 14 units is the long-acting insulin. Again, you are giving another shot at what time? Night. So what is the main meal for us? Lunch. So for the lunch, breakfast, you are giving the 6 units for regular insulin. Out of the 20 units of mixed 6 units are there, the regular. That will take care of the breakfast post hyperglycemia. But the lunch, that 14 units may not sufficient as a long-acting insulin. Okay. This 14 units long-acting insulin has to act till 7 p.m. or the 9 p.m. or the 10 p.m. So that means out of the 14 units, maybe 8 or 9 units are required, maybe acting for the lunch period. That may not be sufficient for the lunch. So for that reason, say no to the mixed insulins and the GDMs. Give only regular insulin. If they require, you give 2 shots before breakfast and before lunch. Usually we prefer breakfast and the lunch. We don't prefer the dinner time because in true GDM, the fasting blood sugar will be much lesser when compared to the postprandial blood sugars. If the fasting is much more, definitely you have to give some basal insulin there. So this is how we have to treat the insulins. These are the requirements. Now case 24-year-old primee with type 1 diabetes and multiple daily insulin injection regimens present to your office for a follow-up visit. Type 1 diabetes, 24 years, maybe basal bolus therapy. Her pre-breakfast glucose 285, pre-dinner 95 and 68 at 3 a.m. How will you treat her diabetes? So fasting how much? Very high. 3 a.m. 68. That is the Somaji phenomenon. So post hypoglycemic hyperglycemia. So she is getting hypoglycemia at 3 a.m. because of the hypoglycemia, counter-regulatory hormones are releasing, and these counter-regulatory hormones are causing fasting hyperglycemia. So how will you treat your diabetes? Reduce the nighttime injection dose. So this is a pump in pregnancy. So advantages are there. Reduces the rates of hypoglycemia, improves glycemic control, easier dosages, and big disadvantage is the cost. Now 32-year-old lady, type 2 diabetes for 6 years duration. She is on treatment with a combination of the glibenclamide and the metformin. She has recently learned that she is pregnant. Fasting 80, postprandial 118, HbA1c 6.1. You advise her to switch over to the insulin, but she is not keen. What would you tell her? So good control. A1C 6.1, fasting is good, PP is good. So she's on glibenclamide and metformin. Both are good drugs in the pregnancy. Glibenclamide does not cross the placental barrier. Metformin is the safe. So continue the same, but always advise her insulin therapy. If not, suppose if the patient is not on glibenclamide, she is on glimepiride, your favorite sulfonylureas, then change the glimepiride to the glibenclamide. Okay, because she is not interested in the insulin therapy. So oral diabetic agents have been traditionally considered to be contraindicated in the pregnancy. However, recent evidence, a rule look at the load of the sum of these joints in pregnancy, particularly glibenclamide, metformin, and acarbose. These three agents are classified as FDA category B drugs. Acarbose to reduce your intestinal absorption of your glucose, but acarbose will have a lot of the gastrointestinal side effects like nausea, vomiting, cramps, diarrhea, etc. In pregnancy, most of these pregnant women will have some gastrointestinal upset. So in that way, we don't consider the acarbose as the drug of the choice, drug to be used in the pregnancy. In some people, when there is no gastrointestinal side effects, you can start using the acarbose. But my favorite drugs are metformin number 1, sometimes glibenclamide, very rarely acarbose. Here another case, a 31-year-old preemie, diabetes during the 12th week of the gestation. Metformin, she has been using for this polycystic ovarian disease for the past 4 years. Can metformin be continued during the pregnancy? If so, till what time? But traditionally, it's safe in the pregnancy. But what the book says that better to avoid in the first trimester of the pregnancy, at least in the second trimester of the pregnancy. The third trimester, second trimester is so safe. In the first trimester, having know that the person is in a pregnant, already she is on metformin therapy for so many years. You have the two options: continue the same, or you can change over to the insulin therapy. Yeah, 12 weeks. So metformin is a bigonide which acts as an insulin sensitizer, most widely prescribed anti-diabetic agent in the world, accepted as a first-line therapeutic agent for type 2 diabetes for most national and international agents. Some women in the reproductive age group may be on metformin for gynecological indications like PCOD. The first studies on the use of metformin in pregnancy were conducted in the 70s, showed no difference in perinatal mortality compared to the insulin levels. Later studies raise concern regarding the increased incidence of preeclampsia in women using the metformin. So that is the reason. So there is a little confusion, or a little remark will be there on the metformin as far as the increased incidence of the preeclampsia is there. Then you can give an idea to the patient. So you are using the metformin for the last 4 years for the management of our PCOD. Now you are pregnant. So you can continue the metformin. Better to use the insulin to avoid this preeclampsia risk. Suppose the patient says the yes for the insulin, you can continue the insulin. Otherwise, you can continue the metformin. But you should know that metformin is not 100% safe. So there may be a chances of preeclampsia in these women. 751 women with GDM randomly assigned to 20 to 33 weeks. MIG means metformin in gestational study. Primary outcome, a composite of neonatal hypoglycemia, respiratory distress, need for phototherapy, birth trauma, 5-minute Apgar score less than the 7 or prematurity. So these are the results. They studied, they given the metformin and they studied here. See, 92% of the women continued the metformin to the term. 46% needed the supplemental insulin. No significant difference in the primary composite outcome between the groups. No serious adverse events with the metformin. Women preferred metformin to the insulin because it is oral form. So possible concerns, placenta transfer of 10 to 16% neonatal hypoglycemia. Metformin is not accepted as the first-line pharmacotherapy for GDM in US. Women on metformin PCOD can continue the drug. Glibenclamide. So long half-life can be given once or twice daily. Dosage is 2.5 to 20 milligrams per day. Now the 5 milligrams tablets is available. Your Dionyl, favorite brand name Dionyl, and semi-Dionyl, that is 2.5 is available. Unlike other sulfonylureas, it does not cross the placental barrier, probably due to the high degree of the protein binding. Hence, fetal exposure is very, very minimal. So, hypoxia is not there. So, more evidence is needed before the glibenclamide can be recommended as a first-line agent for the diabetes in pregnancy. Other drugs, not enough evidence for safety and efficacy of thiazolidinediones or pioglitazone, DP4 inhibitors, GLP-1 analogs in the pregnancy. Therefore, their use cannot be recommended at the present time. Psychosocial aspects. Diagnosis of the diabetes is a significant stress even in the non-pregnant state. Pregnancy itself is a stressful situation. Diabetes in pregnancy can be expected to be associated with significant stress. Stress has adverse effects not only on the health of the mother but also on the unborn baby. So stress can make control of the diabetes difficult or even impossible. So psychosocial factors are also very much important in all the GDM population. So all healthcare providers who deal with the antenatal women should be aware of the unique psychosocial stresses that accompany the pregnancy complicated by the diabetes. Should be trained in taking at least a brief psychosocial history. Every antenatal and the postnatal woman with diabetes should be questioned about fears, anxiety related to her unborn child's health, her own health, or her family and the social health. I don't think that our busy OBG population, they may not spend time on these psychosocial issues. But please see that all the GDMs you have to pay a little more attention, these people, because these factors are also very, very important. So same thing. So last one, if psychological or psychiatric morbidity is significant, referral to a qualified mental health care professionals, so psychiatrist or psychologist, is also indicated in some individuals. So take home messages. Women with pre-existing diabetes should attain optimal glycemic targets prior to the conception. In women with GDM, medical nutrition therapy is the first line of the management. If glycemic targets are not achieved with MNT, then the pharmacotherapy is almost indicated. And insulin is the drug of the choice. Metformin can be continued during pregnancy in women who have been receiving for PCOD before the conception. So that finishes out 75% of our talk. Another 20 minutes.